Outside of medicine, he enjoys running and hiking. And his clinical practice is primarily in the intensive care, in intensive care medicine in the medical ICU here at UVA. He also sees long COVID patients at the UVA Health Pulmonary Clinic and the ICU Recovery Clinic. So we're glad to have Dr. Enfield joining us today to discuss long COVID. So with that, I will hand it to you. Thank you for joining us.
Thanks, Lori, and thanks for having me today. Hopefully this will be an informative talk, and hopefully we'll have some time for discussion. Long COVID, as many of you are aware, is a disease that we are still coming to terms with. And I think, it's going to be, and I'm excited because it's one of the few areas where I can say there's new research every day. In fact, I sometimes have to change my slides the day before presentations to add in articles that came out the day before. So whatever I say today is probably only useful to you for the next 24 hours, but hopefully it will serve as a primer if for those of you who have not had time to look at a lot of the recent data and maybe spark some conversations about how the Long COVID Clinic at UVA can help your clinic better or you better. I jokingly told people, and I still hold this true, a few months ago when we were applying for a grant that we did not receive, that my real goal for seeing long COVID patients in our pulmonary clinic is to put ourselves out of business, because there is a growing number of these patients, and many of the conditions can be very well treated locally by their primary care physician, but we also know that it's a very daunting task sometimes to look through these patients. And so our goal is to really try to create tools that other people can use to do their job better. I also like to tell everybody that, I started my life at UVA having a background in epidemiology. I think when I was first recruited by Jerry Donowitz to come as an intern, he was really expecting me to go into infectious disease. And then I got really excited about critical care. And at one point in time, I was like, well, this is a great blending of life. I can do some critical care. And maybe if I'm really lucky, there'll be one global pandemic in my lifetime that I'll really get to sink my teeth into. I have since regretted ever saying that, having now lived through the flu pandemic in 2009, followed by a measles outbreak in Charlottesville, followed by a global spread of Ebola, and now COVID-19. And if I never see another pandemic again, I will be very happy. However, I'm not holding my breath for that. I am going to... I can get my slides to now work with me here. I do want to acknowledge that I work for the University of Virginia, which was built by enslaved laborers on the Monacan tribal lands, and that this was really built on the backs of Black people with a history of eugenics and the support of segregated schools. So UVA has a long road ahead of us as we try to work to be both good and great to the state and to the nation. This is really important as we think about COVID and some of the information that I'm going to present today with long COVID, because we still have access to care issues that are built on systemic racism. And much of what we see in our long COVID clinic and in the data from long COVID reflects a singular experience of white population, particularly the white population who is able to seek care through specialty clinics. And my hope is that the long COVID clinic will be able to be a clinic in a space for all people. But specifically, as I said, we're a very small clinic, and there's only 2 of us that see patients a half day a week on Mondays. And so we hope more to be a resource to the Commonwealth where we can spread information. I'm also, before I get into a lot of our long COVID data, I'm going to acknowledge that our long COVID clinic is really a labor of love for Alex Cottle and myself. It started from our post-ICU discharge clinic. We saw very early on many patients coming to our ICU that were young. We knew they were going to have needs. We started having them come to our post-ICU discharge clinic, and then getting calls about patients that had very similar features that had never been in the ICU or maybe never hospitalized. And so we started seeing them. But it really wouldn't work with just Alex and I there. The real backbone of our clinic is actually our physical therapist, Talia Pollock, who has taught me more about recovery from long COVID than anybody else. And so I want to acknowledge her great contribution to our clinic as well. So I'm going to start by this quote from one of the Yale School of Medicine's physicians who point out that post-acute infection syndromes have been going on for decades, maybe even longer, but we didn't pay much attention to them. Historically, they've been ignored, but we weren't able to do that in the wake of the COVID pandemic because so many patients were presenting to their primary care physicians, to hospitals and elsewhere with symptoms that seemed to be following what should have been a normal recovery from their viral illness. And I just got pinged that my headphones are about to die, so hopefully I will change mics if I need to here in just a second. So what we're going to talk about today is what long COVID is, and I'm going to really tell you that there is so many different pathologies that we see in our clinic that I really couldn't do justice to all of them. And I think those of you who are seeing these patients in your clinics will know that people come in with a myriad of symptoms. But I'm going to really focus on sort of the big three that we see: pulmonary syndromes, the myalgic encephalomyelitis or chronic fatigue syndrome, and some of the neurologic and psychiatric symptoms. I do not have any disclosures. I get no grant funding for this, and I don't speak for any pharmaceutical companies. I will discuss some off-label medication uses. That's a typo there. But mostly I'm going to do that to talk about what is being told to patients, both when they get into the Reddit tunnels of the World Wide Web, as well as some of the things that they're going to see online and bring to you, and what we know about some of those uses right now. There are a myriad of terms that are used for long COVID. Post-acute syndrome following SARS-CoV-2 has been referred to as post-acute syndrome following COVID, and several other things. I'm going to try to stick to long COVID because that is the term that was first used by patients. And this term really came out in Facebook among patients and then was adopted globally and likely really should be the term that we use rather than some of these other terms because it describes the patient experience and puts the issue front and center in the terms that are being used by them. So what is the impact? We don't know. Early data said between 10 and 30% of patients have lingering symptoms after infection with SARS-CoV-2. The current numbers and trends indicate that long COVID is our next public health disaster in the making, and that is fairly true. The clinics around the country that see these patients usually have more patients wanting to be seen than can be seen in their clinic. That is true for us. The disease burden is prolonged and is not associated with rapid recovery, and so therefore these patients have healthcare needs that persist for years, and we really don't know for how long because, as I remind every patient that comes into our clinic who's asking for answers, this is a disease that we've known about for a little over 3 years now, and therefore is something that we're still learning a lot about. And that's what I mean by the fact that we're really seeing the tip of the iceberg now, because there are a lot of issues with how we understand this disease. Health inequity, as I've mentioned before, is a significant one. But the other significant one is the lived experience of the patients who come into us frequently and say that we're the first person that has listened to them. Long COVID is frequently denied to them by healthcare providers. They don't want that label because there's some stigma associated with it. And so they oftentimes do not seek attention. There's also, as I said before, a real overwhelm by primary care physician. We often will see patients referred to us for long COVID because the patient has significant symptoms. And after a fairly thorough workup, our intervention is to treat the depression and anxiety they're feeling followed the mental health crisis that also occurred with our pandemic. And in that setting, it's not anyone's fault. It's just that we can allot a little bit more time to doing some screening questionnaires, and we do a lot of workup that's often not available to local physicians. There's also a significant reporting bias, and there's a growing amount of publication bias in this. And one of our best sources of information about long COVID is coming from groups like the Veterans Administration, who really has a very select population and therefore may not be representing the true prevalence and or physiology of the disease. As I said before, there is not an organ system that does not seem to have some degree of involvement in long COVID. Brain fog being one of the first things that were described, anxiety and depression and sleep disturbances. But we also see gastrointestinal complaints, skin disorders, hair loss being very, very common complaint, joint pain, coagulation disorders, both in the near acute setting from COVID, but also long-term, lots of respiratory and cardiovascular complaints, and then fatigue and malaise. And so a host of problems that can come to the attention of providers, and therefore making it very difficult, and likely also representing representing more than one reason for someone to be sick after their recovery. So it's a difficult and frustrating complex disease, and there's a lot of overlap. Patients may have one of those symptoms, or they may have multiple, and so we tend to like grouping these patients in our clinic. We started with the severe COVID patients with respiratory failure, and those patients will go on to develop post-ICU care syndrome, which is completely a different talk, but is common, particularly because we see patients that were hospitalized for very long periods of time for their COVID. This really reflects the initial pandemic and the first few waves of COVID. Some of those patients have persistent pulmonary symptoms. Being a pulmonologist, I pull these out, even though this really belongs in the long COVID bucket. But these are distinct entities that we have often more interventions that we can offer than some of the other long COVID pathologies. There are a number of patients who had moderate COVID disease with hospital admissions that also go on to have persistent symptoms in long COVID. And then there are mild COVID disease that never came to the hospital that can cross over into having persistent pulmonary symptoms and long COVID. As I stated before, our interest at UVA in our clinic really started in the PICS area, or the post-intensive care syndrome area, bridged into the pulmonary symptoms as we saw those patients, and now has really encompassed the whole spectrum of diseases to us. So just a little bit of history. We established our post-COVID clinic in May of 2020. I like to boast that we were trying to be the light in the mind sometimes. We started seeing these patients. This was started by one of our pulmonary fellows who was recognizing a problem and wanted to support it, and has persisted since then. We try to not see patients before they've had 3 months of symptoms following their COVID illness, and that is because initially we were seeing patients sooner, and many of those patients recovered, and so it was taking away clinic space that needed to go to patients that had more persistent problems. We standardize as best we can our initial workup. Everyone gets pulmonary function tests and 6-minute walks. We're a pulmonary clinic. If indicated from that, we get chest imaging. We do a significant number of screening questionnaires that we actually repeat each month. Each time they see us, we like to watch the trends. These are our standardized questionnaires that we'll talk a little bit about, but they screen for anxiety, depression. We do MOCAs on most of our patients as a screening test for dementia. And we do see a significant number of people with abnormal MOCA exams that we often refer to other clinics like neuropsych for evaluation. And then we do some quality of life questionnaires. And that quality of life questionnaires have been very helpful to us, both through monitoring disease progression as well as sort of identifying areas where we can help the patients better. We ended up publishing a very early recovery study. This came out in August of 2020. I think it was one of the first post-ICU recovery that looked at COVID ICU survivors. You can see there, at that point in time, we're seeing patients 6 weeks after their discharge, which was pretty early. We actually had a fairly enriched population for Hispanic patients at that time. Only about 25% of our patients were white. That has dramatically shifted in the years following that. And the Hispanic population has diminished significantly, as has our Black population. Most of these patients came to us having had a history of ICU delirium. So they were very sick. And in that population, we saw a significant amount of pulmonary dysfunction. Only about 61% of them had normal PFTs. And we only saw mild cognitive issues with using screening with the MOCA, but we did see a lot of other psychiatric symptoms, anxiety and depression being the most common one of those. So this is evolved. This is the definition that we use in our clinic. It's fairly standardized across many clinics now. We try to get a probable or confirmed COVID diagnosis. That's increasingly difficult as testing has gone down, and so we're probably seeing some blurring of that now. We try not to see people in the first 12 weeks, and that is because we do see significantly a lot of patients who recover. That is not to be said that there are not some patients that following an acute COVID experience need to be seen sooner, and we're happy to see some of those. I've seen a couple of them recently because there are patients who have fairly debilitating recoveries from long COVID, particularly in the elderly who have other systemic diseases, and early involvement with physical therapy specifically, as well as tailoring of some medications can also often be very important. I think this is probably going to be near and dear to Dr. Archibald's heart, but we see a lot of our geriatric population here where what we do most for them is to stop medications and get them moving again. And that does a lot for them, but it's also a lot of support for their spouse because we see a myriad of symptoms there. We try to look for alternative diagnosis because we do find that some patients had pre-existing issues that have just become exacerbated for one reason or another. And we do really look for impacting daily function. One of the keys, though, is that the symptoms do not have to be persistent daily. Long COVID can fluctuate. People have good days and bad days, and that makes it very difficult for many people to understand. No one has a completely normal day, but often our patients will, tell us, "Hey, today's a really good day," or "Today's a really bad day." They have persistent symptoms, though. As I said, and I apologize, this is a pretty small slide to see, but this is from the Veterans Administration that looked at the impact of long COVID in their population in the first 2 years, and tried to look at disability adjusted life years in 1,000 persons. And what we can see is that in the non-hospitalized, the hospitalized, and just overall, there's a significant amount of disability that ranges in spectrum through all of the organ systems, cardiovascular being amongst the highest, followed by mental health, particularly in the hospitalized patients, and neurologic and pulmonary symptoms there as well. And this holds pretty true for most of the studies I've seen. This is the largest study overall, but it really reflects an enriched population because of the source. And so there's some challenges with it. But I think it does really highlight the fact that the amount of disability is significant for this disease. The CDC published several weeks ago that they believe that around 3,500 people have died specifically from long COVID. Now, there's some issues there because they used death certificates to do that analysis. But we know that this disease impacts a huge number of people. I'm going to skip the pathophysiology because what I'm going to tell you is this is my placeholder to tell you that we're still trying to understand the pathophysiology of this. We don't know why this happens. There's multiple issues going on, but there's a lot of great research happening, and hopefully that will help us in the future. So as I said in the beginning, we're going to really focus on these three areas: pulmonary complications, myalgic encephalomyelitis, and neurologic and psychiatric complications. So in pulmonary complications, I'm going to talk to you about two things. I'm going to talk to you a little bit about traditional pulmonary functions and what we see, but I want to highlight dysfunctional breathing as well. And I'll explain what that means in just a second. But this is the one time I'm gonna talk about a case because I think he really represents the early days of COVID for us. And what we didn't know then, this is an 18-year-old gentleman who came to us. He had been hospitalized locally and then was transported to UVA for potential ECMO. He is not our longest ECMO run for our COVID. We had one patient who went longer than this, but 57 days on ECMO is a very long period of time and really reflects the unknown at that point in time. He spent over 90 days on mechanical ventilation and much longer than that in the hospital. He had every complication that we can think of involving his lungs. He left with what we call an LOSer flap, which is basically a continuous fistula between his pleural space and the environment, and very debilitated. When he was discharged, most people felt that he was going to become sort of a chronic complications of COVID and very dependent on other people. This is his CT scan during initial hospitalization. You can see that there's very little. This is supposed to be his lung. This black space is not his lung. That's just air. This little bit over here is the functional lung that he had during his hospitalization. Very little working. And this is him 10 months post-discharge. And you can see fairly normal, but not normal lung left on his CT scan. And he had significant challenges about 9 months, and these persist today. He has some degree of lung fibrosis that is persistent. But he has no oxygen requirement and is increasingly able to move. 425 meters at 18 years of age is a pretty normal 6-minute walk. I didn't see him. I've not seen him since the summer of 2023. So this actually needs to be updated. But he has returned fully to his university setting, where he maintained a 4.0 GPA and is back to living a fairly normal life. Though not fully normal, he is very anxious about getting sick again. He has a significant amount of anxiety around people who cough, as probably you can expect. But it reflects really that there are these patients that we thought would not recover who do recover. And I want to highlight that because I think it's easy for us to see very critically ill patients and be dismissive of what their outcomes can look like. And he really represents not a majority, but a large number of people who survive their ICU illness. People who didn't survive obviously are not captured here, but of survivors of the initial pandemic, many of them have gone on to being very functional. Our longest ECMO run patient is a gentleman from our local Hispanic population. He came to us, was on ECMO for I can't remember how many days, but forever. He is back to doing his life and has a really great quality of life despite some persistent symptoms, but has really shown just remarkable recovery and is a real testament to us not stopping when many people would have. We think that there's a large range of patients who have respiratory symptoms. And the reason that this range is so large is how you define those respiratory symptoms. But the patients come in and claim that they just cannot move as far as that they used to. They can't exercise much. They get short of breath walking up flights of stairs. And so it really requires us to do pulmonary function tests, 6-minute walks, and often cardiopulmonary exercise testing. What we know 1 year following a SARS-CoV-2 infection is that about 40% of patients will have persistent evidence of ground glass opacities, and about 40% will have some degree of reticulation. There's some that will have some bronchial dilation. About 10% of those patients will have obstructive disease by PFTs. 25% will have restrictive disease, and 20% will also have diffusion abnormalities. And that's obviously combining two different data sets, but it's pretty consistent off of different studies. So there is a significant amount of pulmonary dysfunction, and this includes both patients that were in the ICU and those not in the ICU. So being critically ill is not the marker of who has problems afterwards. The challenge, excuse me, it's the joy of the season. So the challenge that we have is that there are many patients, though, that will go on to having normal lung function and still complain of breathing problems. And these patients often get ignored or told that they have that it's all in their head. But many of them actually have disordered abnormal breathing patterns. So most of us are familiar with the changes in the respiratory cycle that occur with normal activities. As you exercise, you begin to ventilate higher, you hyperventilate in order to respond to that exercise. In some patients that are recovering from SARS-CoV-2, these abnormal breathing patterns persist, and we don't know why it is, but it is becomes very obvious. If you watch these patients in clinic, they will often run out of breath quickly when talking. They will sometimes you'll see that they don't breathe for a period of time. It's almost like they have an apneic spell, and they will uh, take these deep sighing breaths every once in a while, and this causes them to physically feel impaired. There's a fairly reasonable screening questionnaire. This is I'm gonna butcher this name. This is the Najmingan questionnaire. If you actually Google breathing screening questionnaires, this is the one that will come up. There's several questions that we ask: chest pain, blurred vision, dizziness, fast or deep breathing, shortness of breath, tingling of fever, fingers or hands, bloated sensation in stomach. And if you ask these questions to the patient on the scale and you get a score above 23, they probably have some degree of disordered breathing pattern. The United States is probably behind in recognizing this. This has been really looked at in Europe and Australia and New Zealand extensively. There's some great programs that you can learn online, the techniques to examine this. When we do ultrasounds of these patients' diaphragms, we'll see that many of them have diaphragmatic thinning, meaning that the diaphragm is actually not as strong as it was. And we can measure that in different ways and really retrain people to breathe. And I will often say that I'm super happy when we can find a person with disordered breathing patterns, because it's an area where I know that there's an intervention that's going to lead to change that will help that patient. Often disordered breathing patterns coexist with many other things. People have disordered breathing when they become anxious, and people have disordered breathing patterns for other reasons as well. But doing the breathing retraining can really dramatically improve patients' lives. And so when we see a patient that comes in with shortness of breath, after we do this questionnaire for all of them, and include this as part of their therapy, while we are also looking for new onset lung disease or heart disease or other problems that cause respiratory problems. Physiopedia, if you're really interested, is a website that you can go to. They actually have courses on the science of breathing well. It's a pretty good course. They talk about dysfunctional breathing. It can be an interesting thing to learn. I will caveat say that when we have this conversation, and I'm stealing from Talia Pollock, who I mentioned before, we often say, hey, what we're going to talk to you is going to sound a little woo-woo, because people think that we're crazy. But it's pretty fun when they come back a month later and say, I've been doing all those exercises and I feel better now. For people that are, being sent to us, what they're going to get, is we are going to do PFTs and imaging when indicated. We do a lot of echocardiograms. We find a lot of patients that have new onset heart failure. We have had to proceed all the way to right heart catheterizations in a couple of patients where we have diagnosed cardiac abnormalities and pulmonary hypertension that may have be present before, but also persistent afterwards. And so that is sort of our normal workup, along with screening for disordered breathing patterns. I use the term myalgic encephalomyelitis a lot with our patients because chronic fatigue syndrome has a bad connotation. When I was an intern and resident, I often was told this is not, this is kind of not a real disease. I don't think that we should label it that anymore, and I'm going to tell you why based on some recent data in a second. But when you label something as myalgic encephalomyelitis, it makes the patient feel a little better, and it gets the insurance companies to pay a little bit more attention to you because it sounds worse. We know that there's not a lot of specific testing. There's some really good questions that you can ask patients. The one that usually helps me the most is, do you have a crash? That's how the words the patients will use is, I crash after I do things. If I go out and go shopping the next day, I can't do anything. Or I've been doing graded exercise training with my physical therapist, and the day after I exercise, I just worthless to the whole world. We know that it affects a large number of people. Many people have not been diagnosed, and it causes a significant amount of disability. For those who wonder, this is recognized by the American Disability Act as a disability, and so it qualifies for disability under that act. Some disability insurances have to be reminded of that. The people that have this don't function the way they used to. It can fluctuate from day to day and can be very hard to have a job, go to school. It can last for years. We don't always know for long COVID how long it's going to be. Some patients are bedridden. I do telemedicine visits with about 15% of our patients because coming to clinic just exhausts them. And we can have a better visit if I just do it by telemedicine. And that really helped the patient experience with our clinic. Why I say that this is really a real thing. This was published like 2 weeks ago. It made NPR, so it must be good. But this is a group in the Netherlands who took patients that were expressing sort of these crashes. They did exercise testing on them, compared them to healthy controls, and really showed that on all these patients that had sort of this clinical features of chronic fatigue or myalgic encephalomyelitis, they had reduced VO2 max, which is one measure that we get off CPETs. Gas exchange was impaired and peak power output was impaired. And if you do back-to-back testing with these patients, if you do the test on day one and then you repeat the test on the day two, which the patient hates, and so I don't recommend doing that often, these scores go down even further because of that crash. What was unique about this study is they did muscle biopsies. What they found is that after what they found in the biopsy is that there were significant issues with the mitochondria, and there was evidence as well of fibrosis and amyloid deposits within the muscle fibers themselves. So there are structural changes that occur in these patients that may explain some of what's going on. And if the mitochondria systems are down in the muscle, they're probably not functional in other parts of the brain, which may give us a key insight into some of the brain fog symptoms we see as well. But this is new and exciting, and something that we'll have to follow up on. We do have some strategies for teaching and working with these patients. The patients hate to hear this, but I think it's important. The first thing that we do is really acknowledge their symptoms. As I said, at least 40% of our patients will tell us that no one has ever told them that what they're experiencing is experienced by other people, other than what they've read on Reddit or on Facebook. We do not use graded exercise training for these patients. It's been proven not to work. So we work really specifically with physical therapists who have experience with this group of patients, because they can be helped by physical therapy, but it has to be addressed in a different way. We also find a lot of dysfunctional breathing in these patients, and we try to address that. There's a large amount of sleep issues that overlap with this, and working on sleep hygiene can really help the patients, as well as treating their anxiety and depression, as well as just the stress that they're experiencing with this disease. And so referral and training in mindfulness-based stress reduction can be very beneficial to the patient. So as I tell them often, this is not a cure, but a therapy. And then we teach a lot, something that was developed by the National Health Service in the UK, which is Plan, Prioritize, and Pace. We refer to the patients as having an energy envelope. As I said, this can sound a little woo-woo at times, but it helps the patients understand that there's only so much that they're going to be able to do, and so that they have to understand what causes their fatigue, and then to plan appropriately, and then to prioritize those things that they can no longer do in order to maintain that energy envelope. Finally, and so we have some time to talk. I'm going to just briefly talk about some of the neurologic and psychiatric complications that we see. Brain fog, as you know, is very common. It's the term used by patients of forgetfulness or difficulty thinking. Sometimes can almost sound like ADHD. The insomnia, depression, there's a lot of overlap here, and it's very difficult to untangle. And sometimes we do send people for neuropsychiatric testing to try to understand better what may be happening with them. One of the questions, Garish, we do is called the EQ5D5L. You don't need to really remember that, but it is a way for us to look at multiple dimensions of self-care and symptomatology with it, as well as a visual analog scale of how they feel. And that can really help us distinguish some of the psychiatric symptoms. The US normal, if this is really for you to visualize a little bit, but as you can see, the blue is no problems in either mobility, self-care, usual activity, pain or discomfort, or anxiety and depression. And you can see that those blue bars drop down dramatically in the COVID post-outpatient setting. Mobility, usual activities, pain and discomfort and anxiety, all showing more symptomatology. And regardless of severity, we see these impairments. And in some cases, we see the impairments being worse in patients that were never required hospitalization. And that's confusing to us right now, but something we're trying to understand better. Neurocognitive impacts are sometimes more significant in patients with mild original disease. This is an insomnia index, which is another group of another screening test we do, and we see that there's a large number of patients with severe insomnia following their disease, both in all settings, but slightly worse in the outpatient setting. The neuro quality of life is another screening test that looks just at pure quality of life from neurologic issues, and we see that that's impaired as well. The higher score here being representing worse outcomes. And then finally, anxiety, depression, as well as PTSD symptoms are fairly common in all of these groups, and seem to be slightly worse in the outpatient setting and potentially slightly worse in men if you take all the studies now in aggregate together. So all of these problems are common and take up a significant amount of our time. We do find that treating anxiety and depression, both with cognitive behavioral therapy, mindfulness-based stress reductions, and medications is helpful. It is an area where we sometimes have to really collaborate with the primary care physician, and referrals to psychiatry are common, but as many of you know, psychiatric specialists in the state of Virginia are difficult to find sometimes. We do hopefully have a study from the Recovery Network to specifically look at sleep, because that continues to be a challenge for us, and we don't have a lot of answers yet. I will also say that many of our patients get referred to occupational therapy for their neurocognitive problems, and the tools that they learn there are very helpful. Just a few notes on therapies and future directions before I open up for the conversation with you today. And I'll just start by saying that there are multiple trials going on in different phases. The Recovery Network from the NIH is probably going to be the most successful. It is very similar to many other network trials. It's going to be a platform-based trial where many sites are going to be open and actively enrolling. And we hope to start that soon at UVA, though there seems to have been some bottlenecks in the contracting. The first study for that is going to be long Paxlovid, either 15 or 21 days versus placebo, because there is some phase 2 data that is very helpful. But patients are desperate. Rhythm is one of the most common things that I will have patients bring to me. It is a telemedicine company that sees patients in California, Washington, Oregon, Arizona, New York, Florida, Virginia, Texas, and Illinois. And they market themselves as a recovery network. They prescribe many things, including long Paxlovid for patients, low-dose naltrexone, and many other agents, often with either limited or no evidence for support. And the patients that I've had that have gone to Rhythm had a mixed experience with the outcomes, really reflecting, I think, the fact that we don't know a lot about the patients. The challenge for this is that Rhythm is a for-profit company that does not really take insurances. And many of these therapies, like low-dose naltrexone, are not covered, require compounding at a pharmacy, and therefore are sometimes not available to the patients. This is the first thing we tell every patient that comes to our clinic, and is that there's no pharmaceutical therapy for long COVID with phase 3 data. Long Paxlovid, as I said, is the first recovery trial based on the phase 2 data that's available. Low-dose naloxone has gotten a lot of press. It is widely used in Europe and prescribed there. The data in the United States is fairly mixed. And then POTS, which I did not discuss here, is often treated with midodrine and guanfacine. It's still off-label, though many patients do respond to it. We also will sometimes use guanfacine to help with the anxiety and insomnia symptoms in adult patients. It is a central alpha agonist, so has some benefit there. And it's used in children as well as an adjuvant for ADHD. So again, we're getting to a lot of off-label uses here, and we have to do a lot of counseling and more and more frequently, you will see in our notes sort of a informed consent section in the treatment plan, because we do know that what we are doing has limited or no data. So before opening up, just to summarize, it's a complex disease, this long COVID, and I think we're still learning. As I said, some of our data has just come out in the last few months. There are probably multiple diseases being expressed here, or multiple pathologies being expressed, and we truly recognize that there is a huge burden on primary care providers, which means that what we need to do from our long COVID clinic standpoint is provide more support if we can. However, we are an underfunded clinic at UVA and really staffed with 2 people, and probably could be seeing patients every day, but do not have the providers for that. There is, prevention of COVID is really the key here. We do want to see your patients, and please refer them to us. We'll get to them as quickly as possible. I do have a telemedicine clinic that I do for Southwest Virginia that I'm happy to see patients in as well, because we can do many of these things without a physical exam. And we need to try to continue to push clinical trials to help get answers for our patients. We need to have less fear about taking care of long COVID patients, and really work on standard evaluations. Our lack of mental health providers is really limiting what we can do. I will tell you that many of my visits end up being 30-minute counseling sessions, and I am not trained as a counselor, but that's really what I do. And we need better access to physical therapists and tools for physical therapists to support these patients. And finally, a recognition that these clinics need to be multidisciplinary. We would benefit greatly from having a therapist, a psychiatrist, and a pharmacist in our clinic, but because we cannot financially support that, we do it through volunteerism. We've been really fortunate to have people come and help us a lot with these patients, and I really appreciate all the providers who give their time to come see our patients or see them off cycle. Lots of people to thank. I'm going to ignore this, but I really want to highlight Chintan Ramani and Sam Oliver, who were fellows at UVA, who really made this possible through work that was above and beyond, and Talia Pollock, who really brings the physical therapy to our clinic, and has just been a great educational resource for myself as I learn about this. And then Mark Quigg and Eric Davis, who's really helped with the sleep and neurologic complications. These are just the wall of recovery from UVA's special pathogen unit early on, and just highlight that really this is the reason we are here today is because of these heroes who survived their illness. And I will conclude with my favorite quote from Professor Moody: "What we need now is constant vigilance." Thank you.
Wonderful. Thank you, Kyle. It was a great overview of kind of where we are and a lot of ways that we need to move forward. So thank you for that overview. It looks like we do have a question that came in the chat that says, is there any data that you're aware of on reduction of severity with COVID vaccinations? This could be a great way to increase the public's push to get vaccinated.
So there's not great data. I can tell you that there was a look at Paxlovid versus not Paxlovid in the treatment of COVID, and there's no difference in long COVID symptoms in those who receive treatment from Paxlovid and those don't. That was a study that Stanford did and published recently. Anecdotally, I have many patients who will come to me and say, that after they get their COVID boosters, their symptoms get better. And it's all anecdote. I wish I could done. I am hopeful that we actually will have a way of looking at this. There's two databases that have become really useful to us in studying some of this. One is called N3C, which is the National COVID Consortium, something or other, which we have used at UVA to do some work. And then Epic has a new platform called Cosmos, where you can actually look at the medical records of all Epic, all data coming from all institutions that use Epic. And I'm hopeful that Andrew Barrows, who is one of my data science physician colleagues, he and I do work together. We're hoping to actually look at some of those questions of people who got vaccinated and what symptoms they have. And that will be high level. We'll be looking at healthcare utilization following COVID infection and the presence or absence of vaccine. But that's going to take a little while to do that work. And so I'm hoping that we'll be able to answer that question, but right now, no. What I do tell people who remain hesitant about the vaccine is when they ask me about long COVID, is like, well, you can't get long COVID if you don't get COVID. Though I know also recognize that the number of patients who have not gotten COVID, even among the vaccinated, has dramatically decreased. So I think it's a great question, and I'm hoping that someday we'll have an answer.
It'll be exciting to see, and of course, prevention is still, where we need to focus attention as well as identification of burden. Well, great. Well, other questions from the group? We'll open it broadly. Feel free to unmute and ask a question or put it in the chat. We'd love to hear your thoughts, your reflections, your experiences, your questions.
Dr. Enfield, I wonder, in the context of caring for frail elders, you may have someone with or without some cognitive impairment who is on a trajectory of expected decline, may have had a history of COVID that you would know about as a clinician. How do you have any thoughts on kind of teasing out long COVID versus an expected decline or expected cognitive decline in some of our frail elders?
Yeah, totally recognize that as a challenge. And it's not just our frail elders. Many, the challenge that we experience as well is that many of the patients who come to us had other pre-existing issues that may have limited their life. So anxiety and depression that was pre-existing is often worsened after COVID due to multiple things, and definitely after the pandemic. Patients who had underlying cardiac or pulmonary disease can have a worsening of that, and trying to tease out, what is this? This is normal decline versus long COVID is challenging. If we have it available to us, which is very rare, and they have pre-existing neurocognitive testing, often doing repeat neurocognitive testing can give us some degree of, is this out of proportion to where we think they would be? But sometimes we don't have that available to us. And so what I really try to focus on there is can we provide some degree of wraparound services for that patient? I think if I step outside and go to my other passion, which is not where I do any clinical medicine whatsoever, which is sort of longevity and aging. I think, as I've watched my mother age and need more and more support, and as I recognize that I assume we'll, be falling into that generation as well. We know that our understanding of aging probably needs to shift. And so if we can get patients that are in that experience of decline re-engaged with physical therapy and occupational therapy, we've had some success with patients actually seeing improvement where we've reversed what looked like a decline that was significant. So and then again, also looking outside of what we know in long COVID, there's some great work that's been done in Canada with patients that have complex psychiatric illnesses, specifically schizophrenia. And when you can really do great wraparound services with them with social work, physical therapy, psychiatrist, and a clinician, you can see that you can really offset the trajectory of illness significantly. So while we don't have great data on that, I think that is probably what we're going to need to see. But teasing that apart is often difficult. There's a question from Wendy about, does UVA Clinic have data on, hopefully everyone can still hear me because my headphones just died there.
can
Does
hear you
UVA
well.
Clinic have data on rates of recovery? About 25% of our patients right now recover within about 24 months and no longer see us. We have a few that have recovered fully, who insist on coming back for annual visits. It is really fascinating to me. And a few of them, particularly younger patients, younger female patients, will often get referred back to the long COVID clinic, particularly when they're looking at subsequent pregnancies. And I'm not exactly sure what that is about. But 25% is not a great number. That means that 75% of our patients, we don't have a recovery trajectory on them. But as I remind them, we're still in the learning phase of this disease. I will also point out that these chronic post-viral syndromes are really not that new. It's just that they have not been studied widely. We see patients that have similar symptoms that had MERS. If you look in the published literature following the MERS, which is the Middle East Respiratory Syndrome, some people may not remember that, but it was between Ebola and COVID. We thought that was going to be our next pandemic, and we also see similar features in some patients with flu, but we don't have longitudinal data on any of those groups. The data that I showed you from the VA is the really only longitudinal data we have. And Talia just piped in for everyone. I'm just going to read her comment if you can. It's nonlinear, and the waxing and waning part of this is really important. And that is people really do have good days and bad days. I have a couple of patients who were fairly high functioning members of different groups, both in private industry and public service, who really suffered and were on disability for a long period of time, and unable to do any work whatsoever, and now are beginning to return to limited work. But they're returning to limited work still disabled, and we have to work very carefully with them. And I think one of the advocacies that I think all of us as clinicians and non-clinicians need to do is helping the disability programs as well as employers recognize that many of these patients can return if we can support them through part of their recovery. And it's better to get a person back who can work partially than to basically throw these people to the wayside. And so I really want to highlight that that our involvement in helping people obtain a disability and working with employers is very important. And we've had a lot of success stories from people working in industry who just needed a few months off to get their dysfunctional breathing under control, get involved with a physical therapist who knew how to help them, and then to figure out what their energy envelope really was, and then be able to work with their employers to get them back to work. And I've seen people go back to fairly labor-intensive jobs around the state of Virginia, but maybe in a somewhat more limited fashion. So working half-time or working every other day. And many of them are very excited to get back into those situations and really see their mental health improve them. And often those patients self-select out of the clinic because they've gotten back to a good place and they understand their illness. And so I don't know if they go on to recover more, but I'm glad that they're back and functioning at the level that they want to be.
Another question that came in is about the referral process to the long COVID clinic. They wanted to know, what is the referral process? Send a patient to your clinic.
Other questions?
There's a question on how to refer someone to the long COVID clinic. What would be the process there?
Oh, the website phone number for the UVA long COVID is no longer active. Yeah, pulmonary referral is probably the way to go. So our clinic is a labor of love. We have moved our clinic 3 times. We're on our 3rd group of access staff. We're sorry, we just kind of move where they send us. And thank you for Jerry for calling that out. I will make sure our clinic's phone numbers get reactivated. Danielle Nelson in the pulmonary clinic is the nurse who is really working with us. And so that's a problem. Lori just said I've lost audio. Let me see if I can
Are you
fix
able
that
to
because
hear
I'm
us?
definitely not hearing anything. Lori, can you talk to see if I got audio
I
back?
can, yep. Are you able to hear me?
I can hear you again. Sorry about that.
Yay, wonderful. No, you were doing great with the question. I'm sorry to interrupt the question. But the referral process, it sounds like through pulmonology would be the best.
Currently, yeah, and if you put on the referral, Danielle Nelson, she will get us to it. We do screen some of those because there are certain things that I cannot see well. If the patient's primary problem is dermatologic, hair loss, rashes, etc., we will refer those to dermatology because you're not going to get anything from me. When I see a rash, I describe it as red and either blotchy or not blotchy. And most of the rashes I see are usually in the ICU and are very, very bad. And so I would prefer not to see those in the clinic.
Fair enough. We all have our limits. Wonderful. Let's see. Yep. Well, great. Well, I think those are all the questions in the chat. If anyone else has any to ask now, we have a few moments left. I will also mention that in terms of, we talked about kind of the prevention, vaccination, and other resources, identification of patients in the situation, and then the rehab as a long-term process and very specialized. That we're excited to have Talia coming to talk to this group again about the rehab process for long COVID in March. So we look forward to that, and thank you for kind of setting that forward. Talia, looks like you're on today. We look forward to seeing you in March as well. Any other questions in the last few minutes for Dr. Enfield? All right. Well, with that, I echo thank you so much for joining us today, for sharing with us your experiences in COVID and long COVID and where we have to move forward to together. So thank you for that. With that, I'll turn it back to Anthony to wrap us up.
Thank you, everyone, for attending. Like Dr. Archibald Pannoni mentioned, Talia Pollock will speak with us same time on March 20th about the functional implications of long COVID. In between that, on February 14th, the impact team will talk about telehealth optimization and past use during the public health emergency and beyond in congregate facilities relevant to infection control. And we thank everyone. We'd like everyone to stay warm today. I think it's the coldest day thus far. And we hope to see you next month.
And we'll share the continuing ed code as well through the email.
Yeah, I'll send an email out to everyone over the next couple of days with a claim credit slide, as well as a link to the recording of this webinar for future use. So again, thank you all.
Thank you.